First up, we have a cardiac tamponade. A cardiac tamponade occurs when there's buildup of air, blood, or fluid within the pericardial sac, causing compression of the heart. It is important to differentiate between a pericardial effusion and a cardiac tamponade. They are not interchangeable terms, and they are also not a disease progression of moving from the one to the other. A pericardial effusion is a slow collection of fluid. It requires a large amount of fluid to actually cause symptoms, and it's usually infectious or inflammatory in nature. These patients will present with chest pain, shortness of breath, compression of near structures, but they do tend to be more stable. While a cardiac tamponade is usually caused by chest trauma, rupture of an aorta, or rupture of the ventricular wall following an MI. This is a rapid collection of fluid, and any amount of fluid can cause symptoms. These patients are usually more unstable, and if you are lucky, they do present with a Beck's triad. Beck's triad is when there is low blood pressure because of the decreased cardiac output. You have distension of jugular veins, which is caused by the decrease in venous return to the heart, and you also have muffled heart sounds, which is because the fluid around the heart is not a good conductor of the actual heart sounds. But as I said, do not rely only on Beck's triad to make the diagnosis of a cardiac tamponade. Management of a cardiac tamponade is a medical emergency. It needs prompt action and prompt aggressive action, actually. The first thing you will do is an echo in a patient. This is just a video showing what an echo will look like in a cardiac tamponade. So they are doing a 4-chamber view in this patient. What I like about this video is that it actually shows you how the heart will usually look and in what plane of view you are looking at when you're looking with the transducer. So they're flipping it for us. So remember, atriums at the bottom, ventricles at the top. You can see the massive cardiac tamponade causing decreased cardiac output. You can also see that the right ventricle is completely collapsing. This video is at 1/3 of the normal speed. So just to illustrate how it would look in slow motion, it's just now showing you the actual heart. And then this part of the video is just in full speed again. Yeah. So this is what you should see when you do a 4-chamber view of a patient of cardiac tamponade. So when you do an ECG on the patient, they usually present with low QRS complexes as well as electrical alternance. The electrical alternance is caused by the heart swinging within the fluid. So you'll have a large QRS complex when the heart is close to the chest wall, and then you have a small QRS complex when the heart is away from the chest wall again. You will also usually have a sinus tachycardia, as these patients are usually quite unstable. Please do not wait for a chest x-ray to make your diagnosis. These findings are usually more your pericardial effusions, but patients tend to have a cardiomegaly. They tend to have a water bottle shaped heart. There can be pericardial calcifications, but this is once again when it's a pericardial effusion because of clotted blood within the pericardial sac, or it can be something like TB causing inflammatory changes within the pericardium, causing a pericardial effusion. There might be, if it is a true cardiac tamponade, there might be evidence of chest wall trauma, but please do not rely on your chest x-ray to make the diagnosis of a cardiac tamponade. Management of a cardiac tamponade: if this patient is unstable, like most of them are, urgent action is needed. You need to do a needle pericardiocentesis. You have one of two options. You can either do it echo-guided, which is the gold standard, or if there is no sonar available, you can do subxiphoid percutaneous drainage using the anatomical landmarks, but this is obviously a lot more risky. After doing the needle pericardiocentesis, the patient does need definitive management, which is provided by surgery, by either doing a pericardial window in the patient or by doing a thoracotomy. If your patient is stable, you have more time to get surgery involved for a more definitive management. You do not need to do a needle pericardiocentesis in them.